My job is to tell you about the AIS classification. You already know about how to measure angles, what are the curves, what is the alignment, and everything else. And my job is to tell you about the classification and the surgical fusion levels, decision making of what to do when. This is not easy to cover in 12 minutes. However, I will try my best to take you through to the basic principles of surgery. I think the first most important thing is that whenever you do a scoliosis surgery, this is a large surgery, time taking surgery. There's a lot of blood loss in this. And so it is important to understand the patient whom you are going to take up the surgery so that you can ensure lowest morbidity, least number of vertebra fused, have a good sagittal and coronal correction, and prevent further progression. So when you aim for this surgery, then you should have all this in your mind, and you must counsel these patients up for this major surgery. And at the end of the road, your cosmetic results must be better than your radiological outcome. The ideal surgical result is the one where you have the top and the bottom of the fusion mask should be in the stable zone. This was first taught to us by Harrington when he said that it should be in a stable zone, which means if you look at us curved so scoliosis X-ray and you put your hand on the curve, and then you can find out that the above and below curve is straight along the pelvic central sacral vertical line or in the Harrington stable zone, you know that's in the stable zone. The shoulders and the pelvis should be level. And if the fusion goes down to L2, you must make sure that the vertebra is horizontal and neutral and the disc is centered on the sacrum. That's very important. Otherwise, you'll get add-on and coronal decompensation. So basically, it all started with fusion of major curves. And so major curve was defined, and I'll come to that later, from cephalite neutral to caudal neutral. So Harrington said you'd fuse neutral to neutral major curves, and the minor curves or the non-structural curves could balance itself. And that is important to keep in mind when you are doing fusion. So, and also your distal fusion should never end in a kyphotic disc space. So that is why sagittal concepts were introduced by Lenke, and because that was not taken into account in the initial Harrington, which led into flat back, and in the King's classification was basically for thoracic spine. So, and try to leave as much as distal motion segments for lumbar flexibility, and that is how we come to fusion levels. So coming to the classification, there are basically three major areas which you require. So when you see a child with scoliosis, you must first find the age of the child and the growth at which the child is. Then you must look at the balance of the child, the cosmetic balance, the shoulder, the pelvis, the flanks, the arms, the hips, what is in balance, what is out of balance. Because you can have a lanky 1C which is well balanced and finish the growth curve, and you may not want to do anything in those. And then you will, the largest curve, even if it is flexible, is the major curve. And other curves which are either flexible or non-flexible are called structural or non-structural curves. So this is the Lenke's classification, and it is important to go through this slide a little bit in detail. So Lenke said that there are 6 curves. So first is the major thoracic curve. The major thoracic curve is a thoracic curve which is a long curve. So it can be anywhere between the apex, depending on the apex, it can be anywhere between T2 to T5 to T11, 12 disc, and that is the major thoracic curve. So that is the first curve. Then is the double thoracic. So if you have a proximal thoracic, which is become structural, that is a double thoracic curve. And if distal to the thoracic curve, the thoracolumbar has become structural, it is a thoracolumbar or a double major curve. And then type 4 curve is a triple curve, which is structural, which is very rare. So you just see about 1% of these curves in your clinical practice. The maximum 60 to 70% are type 1. So this is important to understand. And that is where selective thoracic fusion and other things come in. Type 1 form about 50 to 60%, type 2 form about 15 to 20%, type 3 also 15 to 20% or 10%, and type 5 is about 10%. So type 6 and type 4 are very rare, 1 or 2% each. That was the first criteria. The second criteria was, since we are seeing in clinical practice mostly type 1 and type 2, you are looking at the lumbar coronal balance. So so that's why he brought in a lumbar modifier. So if the central sacral vertical line is between the pedicles, that is, you look at the lumbar curve, you look at the lumbar vertebra, which is laterally deviated and horizontal, that is at the apex, near the apex, and that is the you have to check whether the central sacral vertical line is passing through the pedicle, is deviated from it, or it is outside it. So that is how you have lumbar modifier A, B, and C. Then, as I said, since type 1 curve is the commonest curve, if it and it comes as a major thoracic curve, over a period of time, the proximal thoracic and the thoracolumbar may become also structural. And that is how you get type 1 and type 2 and type 3 curves. And it is important that sometimes something which may be looking like a type 1 curve may be having kyphosis. So Lenke put in the sagittal modifier, so that if there is in T2, T5 proximal thoracic, the kyphosis is more than 20 degree, then that is also called a structural curve. And similarly, in a thoracolumbar area, if the T10 to TL2 kyphosis is more than 20, that is also a structural curve. So this is also important to keep in mind. So first you will see which is the curve, then you will see what is the modifier, then you will check what is the sagittal profile, and then you will classify this. So as I said, type 4 and 6 are less common. You find mainly type 1, and type 1C is when you have an adult, when you have a completely S-shaped curve where both may be balanced. So these are things which you will have to think about whether you want to offer them surgery or not. Normally, we offer surgery when the curve is out of balance, more than 50 degrees, some growth is remaining, the pelvis is, the shoulders are not in balance, and you know that the curve is growing. So coming to fusion, I think it is important to spend a few minutes in this fusion. First, Harrington, as I said earlier, Harrington in 1966 said, well, the Harrington rod was you fix from stable to stable zone. So he drew a line parallel along the sacral facets up, and the fusion mass should be in the stable zone. Then introduced the concept of neutral vertebra. So neutral vertebra is the vertebra in which both the pedicles are neutral. So that is normally below the end vertebra of the curve. We all know how to measure the Cobb's angle, and we know which is the apical vertebra, which is the neutral vertebra, which is the end vertebra, which is the stable vertebra. And then the Suk found that the neutral, if you start in by 2003, he was using pedicle screws. So on all pedicle screws construct, he found that if you use just pedicle screws right up to T1 or T2, then you could, and distal lower end vertebra, you could go cranial to the neutral vertebra, 1 minus neutral vertebra. Now coming to which should be the upper instrumented selection. As I said, type 1, 3, and 6. There the proximal thoracic curve is non-structural. So depending on the shoulder balance, you can decide where to end your fixation. So for these, there is a standard rule which if you want, there are lots of rules in this, and there are lots of dilemmas in this, because I'll come to the 2 and 4 now. So if you go for a standard rule, if your left shoulder is high, then you go up to T2. If for a neutral shoulder, you go up to T3, is balanced. And if T4 is for a high right shoulder. So that is what is a standard formula for type 1, 3, and 6, because the proximal thoracic curve is flexible or non-structural. For type 2 and 4, which up to 4 is very rare, as I said, for type 2, which is a double thoracic curve, it all depends on the rigidity of the proximal thoracic curve. And there is a lot of debate on that, and even I am not sure as to what is to be done. But essentially, you must include a rigid curve, as I said initially. So your structural curve should be included in the fusion. So you can include both the curves. However, what is more important is that if there are two things here in the shoulder balance. One is the medial shoulder balance, one is the lateral shoulder balance. So medial shoulder balance is depending on the T1 tilt. So if the T1 is tilted higher and the left side is higher, that is a positive T1 tilt. Similarly, if the acromion is tilted higher than from the right side, it's a positive shoulder tilt. So that is important. And also the shoulder morphology is looked into. So the cosmetic picture of the shoulder is also important, because that is what the patient feels or sees. And that is important to keep that in mind for type 2 and 4. Type 5 is a lumbar curve, so that the upper end vertebra should not go beyond the lumbar curve. Coming to the lower instrumented vertebra, there are some new terminologies which have been brought in. So basically, there is a lot of controversy because, as I said, the most common scoliosis is the major thoracic, so type 1, then comes type 2, and so from type 1 to type 4, you have a similar lower instrumented level, but it all depends on the sagittal profile and the rotation on selecting the LIV, and that is important. So, if you look at this Indian Spine Journal, which is the last issue, which is a symposium on scoliosis, you will find that Lenke himself has written this chapter. We've invited him, and he puts in a table of 15 possible solutions. So, essentially, to keep it nice and simple, there are two terminologies which have been introduced. One is the last touched vertebra of the CSVL, or the last substantially touched vertebra or neutral vertebra. It is always safest to have your LIV at the neutral vertebra. However, if you use the neutral vertebra, you will not be saving motion segments. So, substantially touched vertebra, which normally is above the neutral vertebra, not always though, and that would be medial to the pedicle. Last touch vertebra is if the CSVL is just touching any part of the vertebral part. And so you will have to consider when and where, depending on the balance, the rotation of the lumbar vertebra, and what level. Is it junctional? It is better to be out of the junction. So also the sagittal profile, you should look at last lordotic, most proximal lordotic lumbar vertebra, or just stable sagittal vertebra. So that is also another concept which is important. So these 4 or 5 things have to be looked when you are considering the LIV. Since Lenke 1A curves are quite common, there is an adding on. He found I think Newton did a study, and he found that the L4. So normally you have a right-sided thoracic curve in a type 1, and so the lumbar curve should be left-sided. However, there are situations where the lumbar L4 is tilted to the right side. And in such situations, you may get add-ons. So that is important to keep in mind. So there was a sub-classification of the type 1, which is 1A R curve and 1A L curve. Let's take some examples. So I've told you about this classification. I've told you about the upper instrumented level and the lower instrumented level. And I told you the philosophy about it. Now, let me take you through some of my cases so you can understand it better. And you always don't have to follow the rules. Sometimes you may have to break the rules, especially to preserve motion segments or to create balance. Sometimes you may have to go more and less. So this is a child with the right-sided main thoracic curve. This is a Lenke 1A, right shoulder up, apex was at 10-11. So the major thoracic curves have a long curve. So they can be long, they can be short. The apex can be higher, it can be lower. So that is all very important to keep in mind. The T1, T5 was a minor non-structural curve, and the main thoracic structural curve had a curve of 76. So these are the bending films, as you can see. So this has a lumbar modifier A. Now, if you look at this slide, and if you look at the green line, which is the CSVL, you can see that the stable vertebra is L3, right? And that is also the neutral vertebra, and it's more or less neutral vertebra. Then substantially touched vertebra is L2, and the last touch vertebra is L1. So you can always debate in mind in order to save levels, but then you have to take everything into consideration. And his coronal balance is +3. So we did for to L3, and we had a good balance in this patient. This is another child, Lenke 1A, and 14-year female, and this is the curve. I'll have to go quickly because I see I'm running out of time. T1 to T4 is 26, T5 to T11 is 60 degrees, and T12 to L4 is 26. But on bending films, the lumbar curve completely corrects out, and so does the proximal thoracic. So this is a type 1A. And because there is no kyphosis and there is normal alignment. So the neutral vertebra and stable vertebra are L2 in this. And so we fixed it from T3 to L1. And you can see there's a good alignment in this case. So this is another case. This is Lenke 2. So Lenke 2 is a major thoracic and a thoracolumbar curve. And you can see the thoracic curve measures 33, the thoracolumbar curves measure 73. And these are the bending films. So both the curves are major curves. And here the stable vertebra was L5. And if you look at the CSVL, here you think you're a dilemma. Will you still to fuse to the stable vertebra? Will you fuse to the last substantial vertebra is not there, that is this L5. So, but the L4 is large test vertebra. So we have gone to L4 in that. So there was a good coronal balance. So this is because you want to save levels and you have to think twice. This was already reserved for, so you have to think twice before you want to go to L5. And especially T1 and L5, you have to think 2-3 times really before you want to go into them. So this is a 2-year follow-up of this patient. I have a longer follow-up, but I haven't got the pictures now. So this is a 3B, and I'll quickly go through this pictures. There is a T1 curve, the T1 to T5 is 24. So this is also important to keep in mind. The lateral bending films are supine bending films. So sometimes the proximal thoracic bending may not be very good and may not be either by the radiographer or by the, maybe a challenge. So that is also important because there are so many ifs and buts in there. The neutral vertebra was L5. And I was, as I said earlier, I am very reluctant to go into L5. I went to L4. And we used in proximal thoracic, sometimes you can use a hook to try to bring it down and a pedicle screw to try to derotate it. So I've used this combination. Another curve, this is a 4A curve. I think I will skip 4A because this is less common. However, just to show you in these large curves, you may have to do a longer fixation. And still here, as you can see, I have left the L4. There's a 12-month follow-up in this. And the patient is otherwise cosmetically happy. You can see this X-ray hole standing film and this well-balanced shoulder and well-balanced pelvis in this patient. Coming a few lines on thoracic or thoracolumbar selective fusion. So selective fusion we normally would do for a major thoracic or a type 5 lumbus. So, but however, as I have already said, we always want to save fusion levels. So you can also do selective fusion for Lenke 1 to 4 sometimes. And Lenke 1 and 2, most of the times you want to be as selective as you can. However, the Lenke has laid down some criterias so that basically the lumbar selective means you are leaving as much mobile segments in the lumbar spine. So essentially it should be less, the curve should be less than the thoracic spine. The curve should be less rotated than the thoracic spine. The translation should also be less than the thoracic spine. In other words, the thoracic spine should be larger, stiffer than the lumbar spine. And you can undercorrect the thoracic spine with selective fusion so that the lumbar spine also spontaneously corrects to some extent and get a balance. So that is the philosophy. And so there are some selective fusion criterias. And so the AVT ratio, apical vertebral translation, if you draw a plumb line from C7, I think Arvind must have spoken to you all about this. So the AVT, the AVR, and should be more than 1.2. So that means the thoracic spine should have a larger, stiffer curve than the lumbar spine. Waistline asymmetry should not be too much. And that is important also because you must look at the cosmetic part of it. Otherwise, it is better to tend to be on the safer side and do a longer fusion. So this is a case where this is a Lenke 1C where you can easily see this is a very good case for a selective thoracic fusion. The lumbar curves opens out. So in this we did a selective thoracic fusion and I undercorrect a little bit, but the patient gradually compensates and corrects. This is a 5C and lumbar 5 curves we used to normally operate them anteriorly, but now most of these patients we do them posteriorly. I don't see so much of lumbar 5 curves in my practice. And this is a case where I still didn't go to L5. I wanted to save the level. As you can see, I'm still a little off balance. Time will say. So this is after 18 months follow-up and the patient has balanced a little bit herself. So this is a Lenke type C. This is also very unusual or uncommon. So I will not spend much time on it. And there you have to go higher up the end. So I did a longer fusion in this. Rotation is an issue here, so you will have to make sure you correct the rotation. Shoulder balance. I've already spoken about the shoulder balance. So if the upper thoracic curve is got a stiff curve, if the cob is greater than 30 degrees, if there is rotation, is the apical translation, and the left shoulder elevation, and if the T1 tilt is towards the concavity of the curve, that means it's tilted to concavity, then you probably have to do a, you have to take that curve in. However, there are some times where you can, if you find that it is balanced, you could leave that proximal thoracic curve also. This is preoperative shoulder level is actually very important because most of the patients would want to go and would like to have a good shoulder balance because this is what they see. So elevated right shoulder generally gets balanced. As I said, in type 1, type 3 and type 6, the proximal thoracic curve is flexible or minor or non-structural, so they will balance themselves. It's in 2 and 4 which is a problem, and basically in 2. So you will have to look at the tilt, the medial shoulder, the tilt, how stiff is the curve, and the T1 tilt and the clavicle tilt, and all that to take into action. There are some alpha and beta angles also been described, but that is too complex to describe here. So this is important to keep in mind. So the shoulder balance is very, very important. There are limitations of Linky classifications, and we have been rule breakers a lot of times, especially when we want to leave the proximal thoracic curve or leave the more fusion, more motion segments below. And if you get a balance right, you can get it right. So there are problems with this, and I think the end is not yet, because as more and more newer methodologies come in, 3D classification comes in, the EOS system comes in. I think Dr. Bhavuk Garg in AIMS has the EOS system where you can see from above that it is basically a rotational deformity, and that has been neglected in the Lenke's classification. And the age of onset also, and that has also been not so much emphasized in this classification. So these are two other things which will also come into play. Then the patient profile, the flexibility of the patient, the balance, all these come to the, so there are always lots of debates in the Lenke classification as to fusion levels, getting balance right. But obviously, you should avoid coronal decompensation. You should avoid add-on, and you should avoid kyphosis, both proximal and distal junction. Thank you very much for your attention.